Okay, so, yeah, so as she was saying, this will be, a lot of this will be discussion. And so we're gonna try to keep it on path as well. So to try to get done in time and not go too far off path. So if there's things that are coming up that are outside of what we were trying to talk about, we'll be putting them over there and then try to get to them at the end during the Q&A. And I'll also be here afterwards once the whole thing's finished if you have any specific questions for me. So I'm Nancy Levison. I'm a Spanish interpreter. I now do court interpreting, but I started out doing medical interpreting. And it's now been a while since I've been interpreting at Seattle Cancer Care Alliance. So I depend on these guys to help keep me, make sure I'm telling you the right information when we get to specific policies and things. But I started interpreting. See, I took Bridging the Gap from Cindy Wrote in 2003, and then I went from there. I worked for the Red Cross Language Bank for a while. I did the Bellevue College program. I got lots of training. I did studying the medical, and I did Seattle Cancer Care Alliance, and I loved working here. I don't know, I guess most of you are already interpreting here. This is my favorite place to do medical interpreting because of the in-depth types of appointments you get to do, and the fact that you have these great people who have very solid understanding of interpreting and policies, and they're there to back you up when you're in these hard situations, which happen no matter what may happen. And then I eventually got court certified too, and now I work in court mostly. So that's me. And what I also wanted to get a feel for who we have in here. How many of you are already interpreting at Seattle Cancer Care Alliance? Who's not yet interpreting at Seattle Cancer? Okay, a few. There's two. I saw 2 hands. Do you guys already do medical interpreting other places? Or
Seattle Children's.
Okay, so everyone in here is pretty familiar with medical interpreting in general, and it's more okay. So some of this is going to be basic information that we'll be going through at the beginning. I'll try to go pretty quickly, so it sounds like everyone has a basic idea of that. But what languages do we have here? We'll start Spanish.
Arabic.
Spanish, Arabic, Vietnamese. Chinese, Russian, did I hear Russian? Swahili. Japanese. Amharic. Wait, what?
Hindi.
Oh, Hindi.
Thai.
Thai. Thai, wow.
French.
Cantonese.
French, Louise. I know Louise goes way back before me. Cantonese. Anything else? Cambodian. Wow, this is a lot of languages in this, not a big room. Burundi? Wow. Okay. So that also means that you guys, to some degree, might experience slightly different situations as far as the differences in what kind of people you're interacting with, the cultures and things like that. So we'll, as much as possible, we'll try to talk through things and figure out and use our guidelines of what are good practices. It's not black and white, right? I think we all know, if you've done medical interpreting, you know it's not easy like ABC now. There's no problem at all. We run into challenges all the time when we're interpreting. At least I do. I hope everyone, I'm not alone in that. So let's see, and I guess those are my questions, so now we can move on. If I can figure out, oh, there we go. This is what we just did. So, a lot of these initial slides are basically taking the guideline policies that Seattle Cancer Care Alliance has for interpreting, and I just put them together so we can kind of go through and talk through it. And this is in here, we all know this, but this is just like, this to me is a guiding principle to keep in mind whenever we're interpreting. What is the real purpose of having a medical interpreter in these encounters is to facilitate understanding in communication between people who are speaking different languages. We're there to make that communication possible. These other people are trying to talk, and if they both spoke English or both spoke Spanish or both spoke Hindi, they wouldn't need the interpreter. So we're there to make that happen, and that's our main goal. So I think it helps to keep thinking about that and to try to step back as much as possible to let that encounter happen between the people. So like I was saying, and I don't know how much you've had the different kinds of trainings where there's the conduit role is your basic, what we're just talking about, facilitating that communication. Sometimes there's a need to do a little bit of something that steps out of that a bit, but as much as possible, we want to stay in that conduit role as much as we can. And be as invisible as possible. It's really great if people are having that communication and they almost forget, not forget too much, they need to remember to pause, but that they're not so aware of, they're not looking over to the interpreter, that they're able to have their communication between themselves. That's the ideal. I mean, you're never going to be invisible, but. So basically, that's what we're trying to do. Make sure that that communication can happen as close as possible to what they would experience if they were speaking the same language and didn't need an interpreter. It's the ideal, but it's obviously not exactly how it is going to be. So what are some of the things that we use to help achieve this goal? Positioning. I know you probably all know all this, but it's really important to make sure that you position yourself so that the two who are speaking can look at each other and speak directly. It doesn't mean they necessarily will. How many times have you had the person that you're interpreting for look at you every time you start talking? Yeah, all the time. So what do you do about that? Does anyone have any hints?
This interpreter misclarification, just want to say that the communication will be easier if you direct communicate with patients and you don't have
yeah, so her basically saying, pointing out to them that they should be communicating directly and looking at each other.
And it has a reason for that.
Yeah, with the reason. And
I was just going to add at the same time, just assure them I'll be listening really carefully to what they say, so that.
Yeah, ensuring them that that you're listening.
And focus sometimes on note taking, so that
I do that one. That's one of mine. I won't look. I try not to look back at them. I try to just keep looking down. So sometimes they get tired of looking at me because I'm not looking at them. Yeah. That one's hard for me sometimes though, because I understand better when I'm looking at the person who's speaking. So I have to balance sometimes, but I do try to.
If possible, I sit next to the patient.
Right. Trying to make, and or even backing, back up a little bit to where it's like they're going to have to turn really hard to make it a little more awkward for them.
Right. Sometimes the rooms are very small, and usually my experience has been that the doctor sits with the back towards the interpreter, and it's sometimes very difficult to hear if they're talking that way and you're in the back, depending on, again, the room.
But do you find that there would be a positioning that would be workable, or is it just that it's impossible?
It depends. I mean, if there's a family with 6 people in the room, it's tough sometimes. But yeah, you should be able to hear both.
Yeah, so in that kind of case, you'd want to ideally try to find a place that you can suggest, but bring it up, like the interpreter's having difficulty hearing, could we switch? Or maybe if you have, maybe that's the only spot you can be, that they just need to be aware they need to speak louder, but bringing it up, making them aware, so you can try to.
Well, sometimes we have to do the interpreting behind the curtain.
Yeah.
So we gotta be able to do it.
That's hard too, to not be able to see when they're saying, now move this way, do a little of that, and I'm like, what? Not sure what that means. In first person, if you all are doing medical interpreting, you probably know you do it all in first person. Why do we do that?
Good communication. You're not part of the conversation.
You're not part of the conversation. It helps facilitate that whole goal we have of making it the direct communication, that they're hearing I and you, and so it just makes it feel more like they're speaking directly to each other. It also reduces confusion, because when they say, she told me last time such and such, and then the other person's like, who's she? Well, it's you. They start getting very confusing sometimes. So always use first person. And if they aren't doing, if the doctor keeps saying, ask her this, ask her that, what do you do?
I let them know that it's going to be more useful and more expedient to use first person. Just speak to the person directly.
Yeah, let them know. Bring it. Tell them that. Sometimes I've told people that. I'd say, you can speak directly to them and I'll interpret. And, really? They speak English? I didn't know. No, but so I think it's important to remember that we're always going to get into situations where it's not quite working for us, but try to bring it up. And I think people want to make it work, especially, I mean, in a medical setting, everyone wants it to work and be effective. So bringing it up.
When you, when you speak a little bit behind the provider, not to just maybe just 20 centimeters maybe, and then you're facing that way the patient, and you can see the face cues that you also need to interpret, because of cultural issues.
Right,
there.
right.
And then the provider is gonna get tired to do this. It's not gonna be doing this, so
But they
that
don't-
you are for sure. You don't have to be behind the provider, just basically next to it, but a little bit behind it,
Right,
so
right,
that like this is not gonna happen, and they facing all the time, and you're facing the patient all the time.
right. Figuring out that wherever that positioning, sometimes it may vary depending on who the people you're interpreting as to which person you need to try to keep away from looking at you, and where you can step out of
Figure
there.
it out.
Get out of their line of sight. Accuracy and totality, I think that's a pretty clear thing for interpreting, that it needs to be accurate and it needs to be everything. Don't
Question.
omit.
I have a question.
Okay.
Like to the totality part, when you see them always, the patient saying, yeah. So you still do the A, B, C, everything. You have to interpret everything. Sometimes they say, I understood, I don't. So you just.
Oh, you mean,
Yeah.
are you asking that, so the provider has said something in English and the patient says they've already understood
Yeah,
it?
and
Do you
the
need to
provider
interpret?
want to go to another thing, like
If but the patient has told you
they
they
understand partially. I mean, like the patient understand half of what the provider is saying. So do you still have to deliver everything which is said? You introduce that to commute to that.
well, so you just said the patient has understood half of what they said. You don't necessarily know which half.
Well, like they say,
So-
I do like also PT and OT, which is more like gesture, like so range of motion, things like that. They say, I got this part, just tell me the second sentence or things like that.
So I don't know if everyone could hear that he's like doing physical therapy and occupational therapy. Well, there is the whole thing where it's the same where people just start speaking in English and are going on without seeming to need interpreting. What I usually would do in something like is I would very clearly specify is the interpreter would like to clarify is the patient wanting to have this fully interpreted, or what's happening? What do you want? And it may be that the patient would say, yeah, I don't need it, but the provider might be concerned and want you to still interpret everything. So my thought, would be, but to not make that decision yourself, but to kind of clarify with the people that you're working with as to what they're wanting as far as interpreting. Because I interpret for people, say in court, where they actually speak really good English and they just start having the conversation. They'll be saying, yeah. They'll talking very colloquial. And if they're both comfortable that they're understanding, that's, in that case, it's their decision. I don't know if there's a policy specific that.
That's one of the challenges I had all the time. Even the provider want to use the time very efficiently. It's not like an education session. It's more like, to go fast. So it's a challenge to insist every time. So.
Well, but if it's just a provider wanting to rush things, that's a little of a danger sign to me, because that may be pressuring the patient to act like they understand.
So actually this just recently came up, and in general, yes, everything should be interpreted if that's your normal interpreting role. But of course it can be that the patient speaks limited English and feels comfortable to have an interpreter there for more difficult appointments, but then if it's more routine and they have done this 3 times, they might feel, I understand, I'll rely on you when I need you. And but then it's very important that you clarify. It's okay that you clarify, that you tell the provider the patient is asking me to do standby interpreting, not interpret everything for this routine procedure because they feel very familiar. Then you need to let the provider know that this is what they're asking and let them make the decision if that's okay or not, because maybe the provider is actually insisting, no. You need to interpret everything. I don't feel comfortable doing this procedure unless they really understand everything. So.
Does the same happen when the provider gives the patient the list of the symptoms, like 20 lists of symptoms that they have to mark what they feel. Do they feel this way around a week or a month, kind of like that? And the patients are the same. Like they don't need to provider to read that. They don't need interpreter to read that too. They just see the form and they think, I'm the same. I don't have anything kind of like that. The answer like the form, like every time they're gonna check your symptoms before you go.
Oh, like a routine question,
Yeah,
every
routine
questions.
yeah.
Are you pregnant? Are you that? Like,
You're
have you ever
right,
got
Hello?
Yes.
Low batteries.
Hello. I think the battery's low because it's flashing. So yeah, that is common because they're getting the information in and they're asking for the same list of symptoms every time. But I would leave it up to the nurse to determine, like if the patient's like, oh, I don't want to go through this whole list. Yeah, I feel the same, like nothing's changed, this and that. The nurse may still insist that thank you. The nurse may still insist that it's necessary for them to go through every single symptom. It's still not, okay, sorry guys.
We can hear you though.
Maybe I'm doing it wrong.
Maybe it's too far away for the
Oh,
Bluetooth.
that's it.
That could be it. Okay, does that answer your question?
So I would,
I would just follow the lead of whoever the medical provider is.
Because in that case, the medical provider is seeing what's happening and that it hasn't been.
You're just an interpreter provider, just like that. So all you do is just interpret. I mean, whatever, just relate to, don't make your own decision. That's not you can yourself in trouble.
That's when you get in trouble, yeah.
And so the one thing if you do go into that standby interpreting mode, does that mean you can just kind of like start checking your messages and like take a little nap?
Yeah, so you'll still take the notes because that's the way you refrain, because you wouldn't, usually with cancer patients, as you know, they do a lot of research even before coming from Europe or Asia. They do like overseas patients, yeah. So they do a lot of research. They talk technical even with the providers. So you couldn't just like suppress their will, bold, and then insist of interpreting everything as long. I mean, you just say it once, you remind a second time, and then keep taking notes.
Right, keep taking it. So if you've been if they've said, I want to do this and just have the interpreter as standby, standby means you're there, you're paying attention. It's harder. I find it much harder when I'm on standby because it's like, you have to pay attention, you have to watch, because sometimes it's even just a look, like they'll pause and kind of look, and I'll just start interpreting. I mean, just because you see that they, I mean, the worst is when they give like that, a doctor gives a 15-minute explanation and the person's like, and then at the end goes, what? Oh no. But anyway, you're still there for them, and I make it clear to them too, at any moment you need any interpreting, be sure to let me know.
Yeah, so part of my introductory process when I am meeting a patient, and this is to answer your question specifically, is let them know what my role is. And I ask them, do you understand a fair bit of English? Do you speak any? And there may be a husband and wife, or may just be one person. And generally speaking, they'll let you know. And then I let them know, I can interpret everything, or I can interpret what you don't quite gather. And the way I do this is that I will constantly be paying attention to you. And if you look at me, that's my cue to go ahead and interpret. Now, during the course of a session, it may come out that the person overestimated their skill level, which is, pretty common. And so at that point, you just have to jump in. And then, of course, prior to the session, let the medical providers know that this is where we are in the situation. And then the other aspect of that is the modality that we use. LEP husband, fully English-speaking wife. So at that point, being able to sit next to the LEP person, and instead of doing consecutive, you do simultaneous in a lower voice in order to enable and expedite the session of the conversation.
It's basically seeing what the needs are. But as far as simultaneous, we have a slide on that in a minute. That can be an answer for people who are able to do simultaneous. Not all interpreters are skilled in simultaneous, in which case you know, your ethical thing is then to do it as consecutive. Or maybe sometimes older patients get confused, or anybody might get confused by simultaneous. So that's something.
Yeah, but with our and facilities within SCCA, you have to practice a lot with simultaneous.
Oh, yeah.
Because of that, you are many times scheduled to work with a provider, I mean, with a family or a relative instead of the patient per se, and you have to let the dynamic of the conversation keep on going. So you're sitting next to the person that needs the interpretation, and you have to keep on. Otherwise, the provider would not leave a space for you to keep on talking, just you know, to the caregivers.
So she's saying that there's times when you're interpreting for someone and it's convenient if you can do the simultaneous so that the conversation.
Pretty much you have to do it that way, or that's not going to happen. Otherwise, you know, the whole conversation is not going to be around, per se, the transplant, but just trying to organize how everybody's going to speak time.
But yeah, and the same is true. Yeah, if two people in the room start having a conversation in the one language, whether it's the family and you need to simultaneously interpret for the provider or vice versa. But it's not a requirement that people are skilled in simultaneous to interpret at Seattle Cancer Care Alliance. So if you do not have that ability or don't feel comfortable with, don't feel like you can do it, and you can't step beyond your abilities.
And we do try to, this is not working out. And we do try to provide notice when possible to Sana or Carla and let them know if we know that you'll be interpreting for a caregiver. In that case, you can say, because then you'll know that it will be simultaneous translation or interpretation you'll be doing. And then you can notify them and say, I'm not comfortable, I'm not skilled enough doing simultaneous, you know, please give the assignment to somebody else. When we can, we will alert them. Sometimes we don't know. Like you say, you may walk into a situation and, oh, I'm interpreting for the caregiver, not for the patient. Okay.
Because that's one thing that's ethics that you need. You can't interpret beyond your abilities, whatever it is, whether it's the topic, the language, whatever.
But it's a team effort as well, so it's really a good thing if we know in advance, and especially because it's not required for you to be an expert.
Right. And to be able to do simultaneous, you have to be doing it a lot all the time. I mean, in court, I do it a lot. I get a lot of practice. But if you're not doing it very often, it's going to be harder, especially in medical stuff that maybe a whole topic you're not even used to on top of things. Okay, practical tips. Asking for a repetition or clarification if you didn't understand something. How do you do that? The interpreter needs clarification, and then you ask for the clarification. So you say to the person that you're not clarifying with, like the provider, the interpreter needs to clarify or needs to ask for repetition, and then you do that. And that way, everyone knows what's going on. It doesn't look like you've just decided to start having a conversation. Or vice versa, if you need to clarify with the provider what they're talking about, you would tell the patient, the interpreter is going to clarify. And how to interrupt a nonstop speaker. I don't know if anyone's ever run into a nonstop speaker. Any hints? Any good ideas? No. Louise.
It's a very good idea if you can have a pre-session. And in that pre-session, explain that the shorter the utterances to interpret will be, the more precise they will be. And sometimes people just start and they never stop. It's very ungraceful to interrupt them, but that's necessary. And sometimes the provider will understand that the provider has to preside and break in and say, no, let's let the interpreter interpret. But they don't always understand that.
Yeah, sometimes they do themselves that.
If there is a free session, then being able to say, for the sake of clarity, the interpreter would suggest that you speak in solely one complete sentence at a time, if that's at all possible.
She said if there wasn't a pre-session. So I want to point out, we're hearing the importance of a pre-session and things about that you want to do ahead of time. But also, and you know what, even if she said that in the pre-session, do you think they always remember it all the way through and they get excited about telling their story? No.
Yeah.
So yeah, you might need to interrupt and give it, please, one sentence at a time, or.
And mental health, yeah, that gets interesting.
Yeah. Like I said, it's not all black and white. And there's also, like, some people use a signal. I mean, maybe you say it in your pre-session that I'll use this signal. or, I mean, even if you haven't, if you kind of do this, I think people, there's some that's kind of universal. It may not stop them.
Something that you encounter very often as well, you have more than one family member, 5 or 6 family members in one session. And then some of them are speak English and mother tongue. And it's again, in Presession, you cannot communicate to them that you need to interpret for the sake of everybody else. So if some start responding to the doctor, and then the doctors normally what they do is they start directing their attention to the ones who speak English.
Yeah.
It's very, very often. And then you really have to talk to everybody in a way, I mean, clarification and explaining this is how the communication will flow better, and it's gonna be for everybody.
Right. This is our duty as interpreters to speak up and and if there's something that's causing difficulty in you being able to fulfill that communication duty, then you let them know and try to figure out what will work.
And in a way, you're in charge of the communication.
Yeah.
That's the reality. So you cannot be shy about.
Right. It's our duty. Yeah, that's our duty to speak up at that time.
I think when I tell providers that, I'm not here, because sometimes they think that you can sight translate for people or walk people to different places, but to let them know that I'm here not to advocate directly for the patient, rather I'm here to advocate for the communication. That
nice, yeah.
That kind of elucidates things.
Right. Oh, and on a nonstop speaker, another thing, this doesn't always work, but you can sometimes watch, people eventually have to breathe. So like when they pause for a second, just start interpreting. And that, it doesn't always stop them though. So sometimes I start and they start again.
Some of them, they have a lot of oxygen.
Yeah, it doesn't always work, yeah. But, and then, so side conversations or people speaking simultaneously. It's the same thing. We have to speak up and say the interpreter is unable to interpret when multiple people are speaking at the same time, and just keep bringing up what are the things that are causing you to not be able to fulfill your duty. And then we have that consecutive versus simultaneous. We've talked about it already now. But another thing to think about, even if you are able to do simultaneous, you're the best simultaneous interpreter in the whole world. I know there's sometimes situations here, but a lot of times the patient is an elderly patient, and it can be, and even just anybody, it could be kind of disconcerting, this simultaneous. It can create, there's a whole bunch of conversation going on. So, I mean, I think we have to be aware too of like whether it works for someone, because it may create confusion or be too much for them.
Common sense.
Note taking and accuracy. How many people here take notes when you interpret?
How many what?
Take notes.
Oh.
Take notes. Who doesn't take notes? At all? Never, ever, anything.
Never, ever.
Wow. Or I don't know. That's interesting. Do you carry a notebook at all?
Yeah.
Pardon me?
Do you even carry some? Could you take notes if you needed to all of a sudden?
If I absolutely needed to, yeah, I can. I mean, I know how to do note hand, so, but it's not necessary. A lot of the communication is in as much as there are words, there are also gestures, and facial gestures and body gestures, both from provider as well as patient. And so I think that's pretty crucial to be, present to that situation and to listen carefully.
I think taking notes is all official. We handle a lot of information at once. There are a lot of list of medication with the transplant patients, and you're an interpreter is multitask. Do your everything, and the patient in front of you, listen to the doctor at some time, and you also, it's important to rephrase everything I was talking about, and that concentration, if you're getting 5, 6 medication in a row, you have to mention all of that. You have to give given also amounts, and that's very sensitive information just to put it on my back. And I think I have a really good memory, but I don't rely on somebody's life that I would say exactly, when we're talking about ml gens and it's just 1 ml wrong, I feel the right.
Well, that's where advocating for the communication and stopping the train and saying, let's do this 1 med at a time.
1 minute at a
I
time.
think
Yeah.
you could.
It depends on experience too, yeah?
Personally, I find out that she said multitasking, you lose concentration.
Yep.
So
When you're taking notes,
she says, yeah, she said you have to pay attention to here, here, and there, and then you have to write. I mean, it's too much. In my case, it works just to pay focused attention to the
Same thing.
conversation. And that works.
I don't see many providers that, or if I've ever encountered any, that would say 1 medication at a time. And even if you tell
There's
them,
always a
but they
list.
can just say just 1 medication, next medication, excuse me, you don't go so fast.
I don't need to say
One
don't
and
go
a
so
half hours
fast.
to
They just say the
interpret.
medication, they say the
It's always a
dosage, and
list.
then we go.
Anyway, okay, so note taking, apparently a controversial subject.
Yeah, write it down.
But I think what it comes down to, I've taken a number of note taking classes over the years, and it's very interesting that I think a lot of people when they first start, if they do take notes, they're trying to write everything down, trying to write a lot of words down, and that doesn't work. I will agree that absolutely you stop listening to the message, you're trying to get words, you're abbreviating, and later it's like, what does CR stand for? I don't know. So the main thing is that you need to be listening to the message and hearing the message. And then I take notes. I take notes, not writing everything, but using symbols as much as possible. I think that's really key because it gets your brain out of that being tied to the words.
Mm-hmm.
We can talk a little more at the end if we have some time about note taking, very briefly. But I think it's important to at least have something where you can, like, you start hearing stuff, numbers or something, that you can write it down so that you do have that, names, numbers. Some of those things are not easy to remember. I mean, they are meaningless without context, unless you always know, I mean, a certain number or whatever.
I think it's fair to say that we all learn and understand in different ways.
Yep. Yeah. So you have to find out you have to figure out what works for you, what works. But the main thing is to listen. The notes should not be if people let the note, I think too many people let the notes drive them, and then but it just throws you off and it gets you.
You don't necessarily you just take your knowledge, you're in the conversation or the conference, and if you let them do everything that's going on, and all of a sudden you say, okay, they hear comments because they're cues when those medication lists are, now we're going to work with the medication list, and they say, okay, now I have to get this done. And so there are things, it's not that you're writing all the time. That's not even possible.
Right.
If you're going to be interpreting. But I think it's also responsible to have this cue or this written situation.
Right.
Yeah, and Nancy was giving some comments on how to make the notes less distracting, right?
Yeah. Oh, yeah. This is the kind of notebook I use. I don't know if anyone knows. And I love these things. I learned them in one of my first note taking, because they're small. Like, I used to have my medical dictionary. I'd have this. I just had these in my hand, and it's really easy to take notes. But like for I like, I just put a little heart, or if I talk, something about talking, just 2 little quotes. The past, future. It's just different kinds of symbols, and it gives you just kind of those little markers of like the 3 things they said. They said 1, 2, 3. These are the points I need to repeat back. And I think it does enable you to do longer utterances then versus having to do the shorter things. But it's about finding what works for you. But I would say that you should have at least the ability to take notes in the time. Like, even if you don't ever take notes, at least have the paper there that you could scribble something down if you do hear something that you know.
I did on my tablet, but then just erase it.
Oh, that's interesting. This is the high-tech guy. I always think about that, but I don't think something about paper is still. And practice. It takes practice. To be able to use symbols, you have to practice. You have to practice taking the notes. Okay. And we talked about that you're supposed to be a conduit as much as possible. So you're not there as the counselor. I think you're not there as their representative. You're not there to advocate for their rights. So that's that whole thing. Like you're saying, you're not there to take them to do this. And it's very clear cut here at Seattle Cancer Care Alliance. I know other facilities, they might not understand that as well, but here it's very clear, and that's what you're expected. And that's what I always liked about interpreting here. It was very clear what I needed to do, and that people would back me up if someone thought I should be doing something different. Professional distance, it's the same. It's more of the same thing. How do you keep that your conduit role? You should never be alone as much as possible. Never be alone with the patient and the family members, except like a pre-session when they first show up. Do the pre-session and then stay away. as much as possible, stay away. That helps avoid a lot of issues. Don't share your personal information. Don't market yourself for future assignments. Don't use their schedule to promote yourself for future assignments. Don't take payment or reward from clients. Some of this that seems kind of obvious. But what if a patient then tries to give you, like it's Christmas and they brought cookies for everybody and they have a little bag of cookies they want to give you?
Well, I would say I would say I cannot get anything.
I had that here once where she was giving gifts to everyone the whole day and she wanted to give me one. I was like, no, I'm sorry, I can't. I've heard some interpreters say that they tell people, I could get fired for that, and that people respect that. I would feel, I just said no, but.
Apple for integration.
Yeah, apples.
Can't provide transportation to clients. I think these are fairly obvious. And don't share your religious or political beliefs. Especially these days, as politics are such a big topic, it'd be easy to accidentally start talking about things, but you don't want to do that.
I don't know what she said. No.
Objectivity, conflict of interest. We talked a little about the conflict of interest earlier in your HIPAA presentation. Objectivity. That's probably, I guess that's kind of, seems obvious, but it might not always be obvious to us in our moment. But that, like, if it's something that's emotional to you, or that you might feel strongly about, you might not be able to interpret, be able to focus. It might just be that it's a situation that's very close to home. This particular kind of cancer is something your mother died from last year or something. There might just be things. And so what do you do if that happens? If you get into you don't realize it ahead of time, but you're in the middle of an assignment and you realize that this is affecting you that much. What do you do?
It's important to recuse oneself.
You should let the provider know as well, the education.
Yeah, you'd need to recuse yourself, because it's that whole thing of needing to, our obligation is to do a good job, be able to do a good job. But I think that in that kind of case, you might need to stay until they can find you would need to stay until you need to work with but bringing it up and making it clear what the situation is.
Little children, they have a phone interpreter, so they can always grab the phone and continue.
Oh, okay.
There's also video remote
That's
interpretation here for most of the clinics.
And telephonic as well. I mean, potentially,
Right.
if you
But-
feel strongly that you can't see, then you could say, and the provider knows to use telephonic.
So you need to do it professionally. You can't just say,
Right.
I don't agree with you, and storm out.
And then let us know so that we can flag that patient as somebody who's either treatment, or like there's something about the patient, you know them, like let us know as well, so that we won't, like the same situation won't occur again.
And so conflict of interest, like you were saying earlier, is that you might think that it's not a conflict of interest because you don't know the person that well, but if they would feel uncomfortable, if they might feel uncomfortable, that could affect their.
Can I ask a question about conflicts of interest? Okay, so I'm in a language group. I'm a Swahili interpreter. There are very few of us. So if I step away, I'm just asking the question, like if I've met that client in a different clinic for something else, and I see that I'm now in a second clinic, another institution, and I'm at least familiar with their other business. And I only picked up, nobody has responded to that that request for an interpreter, and it's now, just in the time for the appointment. So I walk away, then they don't get the service. I'm asking that question because I'm in a limited language group.
Right, and it is different. It's different in that case. I mean, even in court, I've seen where an interpreter would, the judge would say, so I know you're familiar with this person, but it's a hard language, and the person would say it was okay, but I'm not sure if you want to.
Yeah, I would say, oh, look, it's working. Yes, yeah, that's true. And I think that we try to communicate that to our patients. I'm just going to keep it up here.
You try to communicate what?
We do try to communicate that to patients.
What's that?
If they express that, if they know the interpreter, they don't want the interpreter, because they know them. I will have a conversation with the patient or the family member and say, we have a limited number of interpreters who work in this language, so it may be possible that we're not going to be able to get anybody else in person. Mm-hmm. We have the ability to get them a telephonic interpreter or a telephonic interpreter, Swahili. So that is always an option, and the patient can say, yeah, I'm more comfortable with that.
Yeah, that's cool.
So, but yeah, we do, and I know I communicate really closely with Sana and Carla about that as well. So we know which languages those are that have very limited number of interpreters we can use.
Well, many of the Spanish interpreters work at Children's Hospital, and many of the patients with children, we see them here too. So we know them, and in children, we know them from, you know, they are little kids fight, and then keep going with the medical issues and the adulthood. So that's,
Yeah.
That was really big.
Yeah, I mean, sometimes it comes up, sometimes it doesn't. Sometimes patients are like, oh, no, that's fine. You know, yeah, I've seen this interpreter at the UW before, but that's okay. So.
Yeah, and in general, it's not necessarily a conflict of interest if you're acquainted with them in the sense of not a social setting, but if you have interpreted for them at a different hospital, that's okay, unless if they then feel uncomfortable, I mean, you might notice it and mention it to us, or if they do say something, then they let Evelyn know, or the team lets Evelyn know, and we'll just not schedule you for that appointment or find another interpreter. And if we can't find in very limited situations, then we'll just let them know you have this person or nobody. And usually they're happy to have an interpreter after all.
So confidentiality and non-disclosure, I think that was covered in HIPAA. So I'm going to go on. We're talking a lot again. Professionalism, this is kind of obvious too. You should be on time. Should have a professional appearance, have your photo ID badge, be prepared, and not use your phone while you're in the middle of the assignment, and not have loud phone conversations in the lobby, clinic lobbies. And just real quick, the thing is about professionalism, about showing up on time, being professionally dressed and all that, I think that besides just being a good practice in general, I think it helps increase people's confidence in you as an interpreter, which I think gives you a little more authority. And when you do say these things like the interpreter needs to do this or that, people will trust you more and feel like you're speaking as someone who knows about those things. Versus if you show up late and you're running in and your clothes are all messed up or you're dropping your stuff.
Take a shower.
And pre-session, we've hit on this a little bit. This is super important, right? So when you meet the patient at the very beginning, you would want to introduce yourself, who you are, who you're with, that you're the interpreter, and as well with the provider in a more brief form. But this is where you can tell them that you interpret in first person, that you will interpret everything that's said. So they know that. They've been forewarned. If they start saying something that they think you're not going to interpret, they know. They've been forewarned. And that the confidentiality will be maintained. That can be important to people, especially in these situations where it's a small language group or they might feel a little concerned. And then some of these other just practical tips, like some other people have already said about things that they mention in the pre-session. Here's how I work, or please speak in short sentences and do the pauses, or I might use this signal, or the things like that can be really helpful. I would always just tell them, that I'll be right over here waiting in any moment when you need interpreting, just for the whole thing about not being left alone, that I would just say, I'll be out here, or I'll be out in the hall. And so here, the special situations, I had to put these onto the slides because I can't keep track of these myself. But there's 3 slides here about the signatures and the site translation policies here. So these are in the actual written documents. I pulled them out of there. That for transplantation treatment, you may need to sign consent forms, and they receive the details at the initial arrival conference. And if they go forward, they give their approval at the consent conference. So there may be different interpreters at those. And that means that the policy is that the interpreter for the arrival conference signs the consent form during that first meeting, even though the patient hasn't made their mind up yet. And then if there's a different interpreter for the consent conference, that interpreter will sign their full name on the same consent form, signed by the first interpreter, to acknowledge that the patient has agreed to the procedure. I'm just reading it. So, clinical trials, there's the signature stuff too, where you may need to interpret for patients who are participating in clinical trials, and there you would sign the short consent and the witness addendum forms. And that is acceptable and within the scope of the duties here, and it certifies that that research protocol was described to the patient. And the site translation. So I think you probably all know that the policy here at Seattle Cancer Care Alliance is that you don't do site translation of documents. So here, they ideally, the consent form
what that is?
Huh?
Does everybody know what site translation
Is?
Does anybody not know what site translation is or isn't sure? It's when, I'll say it. It's like if you have a document and you read it out loud. It's called translation because it's coming from a written source, and you're doing it on the fly and then making it. Like in court, it's done a lot for people, but here, and it's just a way of ensuring that you don't get put in a position of having to do something that you might not be able to do on the site translation. And it also kind of forces the providers then to be there and go over the forms. It can make things much more effective, because if you're just site translating things, sometimes people aren't following it or whatever, or you get asked questions. So the consent form should be ideally available in the patient's native language, but that's not always going to be true. And so if it's not, the staff member would orally explain the content to the patient, and the interpreter interprets that instead of them handing you the document to site translate. And that's basically the way all things that could be site translated should be working. The provider needs to be reading it or explaining it, and then you're interpreting it.
I have a question related to translation. If the patient is almost deaf or completely deaf and he doesn't do sign language, what do I do? I need to write, right? I need to do a written interpretation.
Actually, that's a good question. There is different methods for deaf people. So it is important that you bring it up if they don't realize that the patient is hard of hearing or cannot understand you. If they don't realize it, then you can mention it, but there are different ways, right? Isn't there relay interpretation where somebody's typing really fast exactly what they're saying so the person can read it if they never learned sign language? There's different methods.
So are you speaking about a patient who doesn't speak American Sign Language because they don't speak English? Because they lost their, like their...
They just lost the hearing.
Okay, so that's a different situation, and I'm not sure, we haven't come across that yet. I mean, we have some elderly patients or some patients who have lost their hearing as a result of treatment, who require a spoken language interpreter, and it's just, you kind of just have to sit really close to them and practically shout into their, but
it was a situation that's really hospital.
Yeah.
And I have to keep writing for a whole hour.
Yeah.
And it is super hard.
Yeah.
So I don't know next time if I have one of these situations at SCCA, I need to know or I don't know.
Yeah.
It is a special situation, so bring it up to us, and then we'll make arrangements. We'll let Evelyn know. It's important that she knows, and then she can talk to the team to figure out what to do about this, because if it was just an English-speaking patient they have sign language, or they will have relay, so that means like somebody's typing in English really fast and they can read it. They have different methods, but the difficulty is they are Vietnamese speaking and then can't read that writing.
Right.
Then that would be a special situation which we would have to cover under special circumstances and discuss that.
I know some hospitals use the pocket talkers that help amplify sound so that's a possibility. I don't know if we have anything like that, but like Suna says, if it's a special situation, let us know and we'll figure it out.
Okay, so I think this is the last one before we get to the scenarios, which we need to get onto. The facility regulations, I think this is all kind of clear-cut stuff. Probably everyone, it's kind of basic stuff that's in your policies about where you park and all of that. Is there any specific?
What's the last one? What is the Dignity Act?
The Washington State Death with Dignity Act.
Basically, in general, the policy is that you shouldn't discriminate against patients, but or basically say, oh, I don't want to be scheduled with this patient. But for us, the idea is that we want to make sure that you are really impartial and there's no, there is objectivity, right? So if you are too attached, let us know, we won't schedule for that patient. Same thing with the situation. Death with dignity can be difficult for you to interpret for personal reasons. If you hence feel too emotionally involved to interpret for that discussion, either it doesn't match with your beliefs, and you really feel strongly about it, or you just had your family member go through something like that. If you feel too attached emotionally that you feel like you're not going to be objective, finish this conversation and let us know, and we won't schedule you for that patient anymore. Oh, everybody knows what death with dignity means. Is there? Yes, exactly.
Is it by law? Oregon, I think.
Yes.
But here too.
Yes.
So,
So.
yeah. So in Washington, there's. I don't know. So in Washington State, there is the option. It goes like a little different by state, but I think you have to consult with like 2 different physicians, and then it's like an involved process. But if somebody has a terminal illness, and there's not going to be any getting better or any treatments that are going to work, and 2 providers have established this with the patient, there is the option to basically, yeah, if it's like euthanasia, I guess, and it's up to the patient, and how that can be done is, different by state. But in Washington, it is possible for the patient to request death with dignity, and so that's just, really, it could be controversial for personal or religious or spiritual reasons or whatever. And so that's the one thing that if you have a problem with that or interpreting for that, you don't have to tell us why. You just can tell us, I don't want to interpret for this situation, and then we'll understand. We wouldn't think you're discriminating against them. We would understand that it's, a personal thing. So.
And as Suna explained, so Rima's right. It's kind of a very involved process, and here at the SCCA, it's managed by our social work department. But also, as Suna said, sometimes it has to be brought up by the patient themselves. It can't be brought up by provider, social, or anybody else but the patient. And so it may come up in a session that you're interpreting for, and you weren't aware that it was going to come up, and you feel strongly that you don't. For your personal reasons, you don't want to interpret for that type of session. All we ask is that you go through the end of that session and then let Suna know, because there will be multiple, conversations with the patient on the topic. And so if you could just complete that first initial conversation and then say, I won't interpret for this patient moving forward, we will make sure that to respect that wish.
Are we told ahead of time what kind of appointment this is?
No,
I
because
no. So how would the interpreter know?
And that's why we're saying, because it could be brought up by the patient in the, you could show up to an appointment and the patient has the intention of asking his social worker about this. And you wouldn't know ahead of time because it's not up to the, so you just kind of, you're thrown into it. So once that initial conversation, there's going to be, beyond that, there's going to be multiple sessions with the social worker. So if after that initial one, you decide I can't interpret for this, patient anymore, that's fine. We will accept that. Just let us know.
You won't, you can't know for the first time because only the patient can bring it up, not the provider, but it'll,
Okay. Can you clarify for interpreter signature? Because as far as my understanding is that interpreter will not sign any form, even clinical staff or the interpret, or even the staff already briefed to the patients, and we are in that session and we did our interpretation already, and they asked us to sign. Like the form, it's a form that the patient already listened to the consent, the nurse already briefed that, and interpreter needs to sign. Interpreter will not sign that.
Yeah, that's what was earlier on the slides. Yes, you do. So basically how it works, sometimes maybe there will be a trial and then they present the information of what will happen in the trial, or if this patient decides to take part in the trial. And then basically maybe you're scheduled to interpret for it, and you interpret what they're explaining to the patient. And at the end, there is a form saying this was interpreted. You sign the form as if you interpreted this to the patient, but maybe the patient won't sign today. They have till another day, maybe next week, to think about if they really want to. They were just told all these risks, right? Now they have to think about it. Maybe they want to think about it, talk to their family, right? So they have some time to make a decision. Maybe next time you won't be scheduled with this patient because you already had another appointment scheduled and you couldn't accept the appointment, right? So maybe then Joe will be scheduled for it to interpret. And now they say, oh, we already explained everything, so now you just sign here. And if you hadn't signed it before, they'll ask him, you signed that everything was interpreted to the patient. And then Joe's going to say, I didn't witness that. I didn't interpret this to the patient. I can't sign it. And then we have a big problem that we basically have to track you down to sign this form that you interpreted it, or they will have to do all the good work that you did interpreting again, and the patient will be annoyed because they have heard it all. And right, so that's why we ask that you sign at that point, even if the patient doesn't sign.
So it is about the research.
So yeah, I think there's two forms that are acceptable for interpreter signature. One is the arrival conference, which is what Sano was describing, and then the short consent form for participation in a research trial.
I was in the conference of prophylactic, but like the nurse already or the counselor already explained prophylactic procedure to the patient. And there's a form the patient needs to sign, the briefer needs to sign, and the interpreter needs to sign too.
Was it for a clinical study? For a trial, I mean?
I don't think so. It's kind of like it's not a clinical.
And this was here at SCCA?
Is there a form at SCCA where there is a line for interpreter and they shouldn't sign it?
I don't think so. The only forms I can think of that interpreters are authorized to sign are the consent forms, the short consent form or the arrival consent form.
And in the place where they need to sign, does it say interpreter signature?
Yes, it says interpreter.
So if it says interpreter signature, it should be fine.
It's usually print and sign, or just print.
Sorry, the research trials, they do have an area for interpreters to sign, and it says interpreter or witness. And I was cross out witness and then sign an interpreter. There's also another form they have that. And sorry, want to bring something about working at SCCA, which you Nancy mentioned, working at a very special place, and there are a lot of circumstances that are going to bring you out of your comfort zone. So at the end, you're going to be dealing with death and life and scenarios that are going to be very tough to deal with, and you have to think about it before you decide to work here, because you cannot always refrain yourself. You have the responsibility with the patient. It's not always easy to say, well, interpreter needs medication. I know this patient is crying out because he's dying, but I cannot take it, so I have to go out. And we have to find somebody else. Right now, we're going to use the phone interpretation. So you really have to think in what degree your body is made for it. And you have choice and listen to these conversations where you can really do this job or not. It's different than other places, definitely. And it's going to be really experience that I encountered at a fusion center a couple of days ago. There was this patient had a colostomy and the back literally burst. So you see, I have never seen anything like that, and it was so difficult for the patient. It's an old woman, and you cannot say, well, I'm sick to my stomach, I gotta get out of here. She didn't speak a word in English. She was receiving chemotherapy, and I didn't want to be there, trust me. But you cannot refrain sometimes. So there are other instances that you're scheduled to work with a patient, all of a sudden something arises, this patient in the middle of the procedure has an allergic reaction, and you have something else going on somewhere else, and sometimes you have to say, no, I can just not live here. So I know that there are a lot of boundaries that you're gonna have to cross working at SCCA, and it's up to you. You don't have to work in a place. It's just a different place, and you're dealing with that pretty much every week.
Yeah, and so in here, you don't necessarily know when you're about to get into a situation that's going to push you that way. So it's just important to be aware that when are you past the point of being able to do it, interpret well, and how do you deal with it professionally? Good point.
Do you mind if we go back to the previous slide really quickly? There were a couple other ones.
This one? Okay.
Yeah, so Zuna, do you want to talk a little bit about the emergency patient hospitalization?
Sure, if that's wanted. So basically, we have set up procedures for emergency hospitalization. As you all know, the SCCA is an outpatient hospital, meaning nobody sleeps here, and it's taking care of the full time as a patient, but they come here for treatment, go home, and then come back for treatment, right? And if a patient's health gets so bad that they need to be hospitalized, so that's what we say, hospitalization. You're thinking, oh, they're already at the SCCA, they're already at the hospital. That means inpatient. They're getting moved to the ER, either to Children's Hospital, if they're a pediatric patient, or they're getting moved to UW Medical Center. And basically, these two facilities are part of the Seattle Cancer Care Alliance, as Evelyn mentioned in her overview of SCCA. And both of these facilities have interpreter services themselves. So they basically have their own interpreters, and usually just transferring one patient, one interpreter to another hospital creates problems, right? You know how that works. So basically, but there is the alliance, and we don't want to remove an interpreter from a patient that is in a difficult situation. So maybe America has a full schedule today, and her first patient that she was scheduled for 2 hours, well, in the first hour they determined, oh, this patient is not doing well, we have to send them with an ambulance to UW. And then America calls me at the AOLTI and will tell me, oh, the staff, SCCA staff, not the patient, but SCCA staff is asking me to go with the patient. So then she will tell me, oh, what do I need to do again? And this is all listed in the policies for SCCA, but I know you don't carry them in your pocket every day. So give me a call, I'll tell you exactly what to do. And it's basically, we have a procedure set up. I will call interpreter services there, let them know our interpreter is coming with this patient in 20 minutes probably. And then I give that interpreter services over there at UW the chance to find their own interpreter. For Spanish, well, that will probably take them an hour or maybe 5 minutes. And if that interpreter comes, or even a Spanish-speaking nurse who says she can take over because she's authorized to do this in Spanish, well, that's good. And then you're dismissed. You can leave and let them take over. And interpreter service from there will be, oh, thank you. But what if it's a language like Swahili? It's going to be hard for them to on the spot find someone. So maybe you are going to be there for a while. Of course, we don't make you stay longer than you're scheduled for, and we know that you have a full schedule and not everything would be at SCCA. So for America's case, maybe she had a full day at SCCA. She called me. I already have Carla working on getting the rest of her days they covered. If it's with us, the appointments, we'll get it covered. That patient at that moment is the priority. And they always have telephonic for more routine things, right? Or I have some other people who might move out of an infusion to cover a transplant appointment or something, right? So we'll work something out. And then same thing with children's. I'll give them the heads up, this person's coming, and they are super happy if if they don't have to find an Urdu interpreter within 15 minutes, right? And that way we don't remove someone. And sometimes it will be hard for you too to just say, no, I can't go because, you see this patient really needs your help right now for interpreting, or it just feels hard to say, no, the policy is telephonic. However, there's 2 community clinics. We would like to work a better system out. The situation is that at Northwest Hospital and at Evergreen Hospital, SCCA is basically a guest in their facilities. There are 2 different entities. The SCCA in Evergreen Hospital in Kirkland is a different entity than Evergreen Hospital itself. So if the patient gets moved to the ER in that community clinic to Evergreen Hospital, we have tried to reach out to the interpreter services there, but basically the whole policy is everything is telephonic. And basically they're just telling me the staff knows to use telephonic interpretation and you have to leave. Basically, you can stay until they arrive at the ER, but then you are supposed to leave. And I know that can be really hard, and I try to reach out to them, and I'm sure that Evelyn will try again, because I understand that a patient can be upset about it. You can explain that the policy is that they use telephonic. And yeah, basically it means we cannot pay you for it when you stay at Evergreen or Northwest Hospital at the ER. Otherwise, the only thing to keep in mind, I will remind you, if you go to UW or UW Medical Center or to Children's, is please, for your timesheets, you'll get paid as usual how long you stay, but please write down how long you were at the other hospital, because we at the end need to bill the clients differently. So if I know you were 4 hours at Children's, then I need to know that.
And please write down the name, whether it's at the front desk or the RN, which provider told us to leave the site.
Yeah, that's always a good practice. If RN Julie requested me to go with the patient, I'm sure that's a good practice.
And even if you know the policy is to go with the patient, when the provider asks you to, just make sure to give us a call just to notify us, even if you know the procedure, just because that way we'll be aware of it. We can make a note of it on our schedule, and we can also let the hospital that's receiving the patient know that you're on the way, and they can already start looking for an interpreter if needed.
Quick question, do you go in the ambulance with the patient?
Yep.
It depends. Sometimes there's not enough space, but usually, yes, you're probably asked to. Our experienced interpreters here will probably know what the best practice is. Usually, I think you will go with the ambulance. If there's really no space, then there's a shuttle. But otherwise, if you go by car, in that only situation, you can bill us for mileage.
Yeah, the paramedics
if it needs to be
always
fast.
want the interpreter with.
Yes, usually that would make sense that they want the interpreter in the ambulance in case something happens on the way.
So then you come back in the shuttle.
And you can come back in the shuttle.
Unless it's after hours, then a nurse will provide you with a voucher with a taxi voucher.
Oh, if you take a voucher, you're reimbursed. Oh, I mean, if you take a taxi, you're reimbursed.
That's it.
Like,
If there's no more shuttle available, then yes, but please take the shuttle.
Yeah.
Scenarios.
And also when communicate that something that's going on, if you have time maybe to do it in the ambulance, something to get in the middle of the situation. Those situations tend to be very chaotic. Like one of the situations I had to go to the hospital, the one was having a heart attack early. So that you don't have too much time to actually call the agent to let them know, hey, this is what I need. But eventually at some point, it's a little bit, it is just so fast and it's so much adrenaline coming out. But you just at some point in the ambulance, you just get something like, hey, cover the rest of the day, because after all, like I'm going to necessary.
Yeah, and during business hours, you can text us also. We prefer a phone call because we'll hear you faster, but if it's really not possible, you can text us or,
Yeah, and in general, I mean, if this somehow happens after hours, like you're scheduled for a patient who's hard of hearing after hours because it's a special situation and we're not reachable, I mean, you do know that you can go to UW and Children's. So if the SCCA staff asks you, just remember to write down the different times.
Okay, did you guys already hand out the scenario sheet?
Oh, it's already, they already
There we
have.
have, okay.
So are we supposed to fill that out and give it to you?
No, we're going to discuss it now.
Oh.
You can take your own notes if you like on that sheet.
Does everyone have the scenario sheet? So these are some scenarios to try to talk through, and it gives us a chance to kind of like deal with how do you think about these things, because as we said, it's not black and white, it's not always a single answer, it's not always obvious. Sometimes it's obvious, some of these might be, but so I was gonna try to give more time to this, but now we got do maybe 20 minutes. We'll see how many we can get through. I put some of the ones at the end are just the ones that weren't as important, so I was hoping we can get through at least the first some of them. So okay, we'll start with I'll read number 1, and I'll give you guys a few seconds to each person think about what you would do, and then we'll talk about it. Did everyone have the sheet? Is anyone missing it? Okay. You are with the patient and the caregiver. A nurse rushes in. The caregiver mumbles angrily that he hates that nurse because she never washes her hands and always seems to have a runny nose. Okay, everyone think for, I'll give you 5 seconds, think about what you would do. Okay, who has an answer?
I would tell the nurse whatever the caregiver said.
You would interpret what the person had said. Right.
Mumbling,
and
interpreting, yeah?
Huh?
Mumbling
it like that. And why is that? Because
You're supposed to interpret.
you interpret everything, right? It may be awkward, it may be uncomfortable, but and what might have prevented that happening? Maybe.
Hadn't sat with the patient.
Huh?
If you weren't sitting with the patient, it says like you're with the patient caregiver and a nurse rushes in, which means there wasn't a medical provider.
Well,
there.
maybe the doctor just walked out and the nurse.
I thought about that. But
That's true.
Maybe there was somebody there.
Well, or the pre-session, letting the.
That's what I was aiming for. Actually, the pre-session. In theory, you've told them that everything can be interpreted. I mean, it doesn't necessarily mean they'll remember it in the moment, but. And yes, that does sound like they're talking to you, which may be because you've been a little bit too close to being alone with them. Okay, so the second one. The patient's caregiver mentions to you that the patient has not taken the full prescribed dose of a certain medication because it causes unpleasant side effects. The caregiver asks you to keep this confidential. Okay.
And it comes to the same thing, right? You're not supposed to be alone with the patient, but by chance, because you were there sitting, behind enough that you could hear that it's a security issue, it's a safety issue. So you have to let the provider know what's going on. That's my personal opinion. Because it could be that it's something going on with the patient or something.
Okay, so and there's 2 ways this could be interpreted. It could be that they're talking, the doctor's right there doing something and they say it to you in the session. In that case, it's pretty clear. You're in a session and you interpret it. But now if we're talking about it where you're out in the lobby and they say this to you. Yeah, first of all, there's why are you sitting there alone with the patient or the caregiver? And so there's another very, very good reason you don't want to be you want to try to be further away. But yeah, it's a safety issue. It's this is a gray area. I had a training where I know that they said, you wouldn't, it's confidential, but here, I called them. I called in the rest of the team here, which is what you should do too when you're not clear on what to do. You have these great people to call on too, but that basically it's like you're part of the medical team at that point, and it's a patient safety issue. And I think the thing you need to think about there though is how do you do this? Ideally, try to get that information to the medical team before you're in the middle of the appointment. Try to do it. Is it easy to go find what doctors they're going to be talking to or nurse or whatever to let them know ahead of time?
No.
No.
Oh, sometimes if you really want to make it happen, you make it happen.
Yeah, you can
Catch them at the door.
And so that's what I was going for. That also, so you haven't managed to find them ahead of time, but you're waiting outside the door, right? So when they show up and are about to walk in, there's a good opportunity to say, wait, I just wanted to mention this. So, yeah, but I think also you'd want to make it clear that they didn't want it to be explained, because that way they can hopefully keep it so it doesn't start to destroy the trust that they have in you as an interpreter.
It actually can happen in circumstances where you're in a meeting and you're interpreting for the caregiver. then the doctor's attention is pulled into the patient, and the caregiver, something happens a lot with teenagers, where the teenager is saying, yes, I'm taking this, I'm like, well, caregiver, you're interpreting for the caregiver, and when she just comes to the point, it's like, hey, she's not really taking the medication, but it's only because he's gonna get angry at me and then all that. So that has happened, and they say, well,
there it's that thing, you're in the session though, and you've said that you're interpreting him.
In that sense, but it does happen.
Yeah. It's a clear-cut answer in that case, but it doesn't make it easy necessarily, but we've got to remember that. Okay. Number 3, the English-speaking daughter of an elderly patient approaches you separately prior to the appointment. She tells you that her mother, who's the patient for whom you'll be interpreting, has dementia, and that in this appointment, the daughter who's talking to you needs to have a frank discussion with the doctor about a difficult decision point in her mother's care. Her mother's not aware of the gravity of the situation, so the daughter requests that you not interpret that part of the conversation. This happened to me. So what do you do?
I would tell the provider what the daughter had told me, and let him decide if I should continue to interpret when the daughter is talking to the doctor, or I would basically let the doctor decide what to do.
So he says you'd tell the doctor what the daughter had said and let the doctor decide. And so then you'd be in the room just not interpreting?
Well, if the doctor decided I should interpret, then I would do it. Otherwise, I would just stand by.
Based on whether the doctor wants you to interpret.
This is the perfect place for appreciation. I think when that situation happened to me, explained to the doctor and the family member that my role was to interpret everything was going on, and I can, if they didn't want me to be doing that, then I have to refrain myself from the job. And then I actually have to call Evelyn in that situation, because I wanted to make sure that if I didn't want to interpret, it was not legal.
So that for you, it happened right in the middle of the appointment?
No, it happened prior to the appointment. The gentleman came approach me.
Right.
We're gonna this is gonna be really hard for her. And then our culture happens a lot that we want to keep the truth away from people.
So it does happen more than
And so it happens several times with children as well. It's something that we face often.
And it's you need to think about it ahead of time, because I had tons of training. I knew the answer that no, I can't agree, and so I'm sitting separately. I was sitting on the other side of the waiting room, but she came over because she wanted to ask me this. So and when she said it to me, for a moment, my temptation was to go, okay, I'll see what I can do. And it's like, no, I can't say that, because that's your gut feel. You want to be helpful. But no, I was like, well, no, I can't do that. I have to interpret everything. And she said to me, she goes, oh, well, if you can't do it, maybe they can get this other, she named another interpreter, because that interpreter knows how to work with us. And I was like, no, it's not that I don't know how to not interpret. What?
I said she mentioned America, right?
Country.
No, but so I talked to her some more. I said, no, I know how to not say anything. But then what she really wanted was to have that private conversation. So when I talked to her, she actually went and found the provider, and they talked ahead of time, and they decided they would go off to a conference room and have their discussion without the patient, and it worked out great. And in the meantime, I called the person who was the current coordinator at Academy Language. I was like, this is what's happening. I'm not sure. I might have to just step out of the room if they're going to try to do this. But anyway, it all worked out. And so that was good. And even as I was standing outside the room, and when they were about to walk in, I did that same thing that you mentioned. Like I said, now this is what's going on in there. And the provider at that point knew. So it was all, it worked well. Until they left to go out of the room, and they said, okay, we can't leave her alone. So interpreter, could you stay here with her? No, sorry, I can't do that either. So they got a nurse.
I think that ethics when you say the word, it's too broad for when coming to interpretation, legal interpretation, the medical interpretation. I think it's a different thing. It's more difficult to see see when it's gray or black or white. It's a lot of, I think, experience and common sense. I call it common sense. There are many things that it just doesn't sound right, but at the same time, it's so difficult. You're in the middle of difficult situations and a lot of stress with family members that it takes you a minute to think what you really have to do. And you can really many times just follow the book on ethics. I mean, there are many things that are very obvious. There are so many things you have to think about it all along.
Yeah, you do. And then also but think about the ethics and where it falls and that whole thing of trying to be as much as possible a conduit. And when you do have to do something a little outside of that you step back to being a conduit as quickly as possible. But tried, and I think, like in this case, thinking about what is their purpose, what were they trying to do? They wanted to have that conversation, so it helped that. And the conversation, they were gone for like half an hour, so it would have been a long time that I would have had to pretend I couldn't interpret for. That's what she said. Just pretend you lost track. I was like, I'm a really bad interpreter for half an hour. I quit. I just can't interpret.
Well, at the end of the day, safety of the patient, which is the most important thing. So sometimes you have to just do judgment.
So even just emphasizing, even in that situation where the provider would have made the decision that it's okay not to interpret this part, it would be better to suggest that they go to a different room because of that awkwardness of 30 minutes of silence from the interpreter, and the patient could even get upset about that too, right?
Yeah, they're not, I mean,
they must know that something is going on.
Yeah.
So yeah, I mean, if I wouldn't ask the provider, do you want me to just stop interpreting? Because it's the patient's right. I mean, that's what you're there for, is the patient has the right to be hearing what's.
In fact, the state's prometric tests require you to report, like it might be life-threatening, as she mentioned, also abuse, things. So it's like social workers, they will tell you, if you think, if you tell us, if you tell me that you're gonna hurt yourself, by law. So it's legal, like I think comes first, yeah.
Yes, so in regards to mandatory reporting and permissive reporting, everything is kept confidential, but there are certain situations where you may be relieved from your confidentiality duties, and if the patient well, first of all, don't be left alone with the patient. If it happens after all, and the patient tells you that they're having suicidal thoughts, this can be a situation that falls under permissive reporting. So it is at this point, because you might be conflicted, I think I should tell someone, but maybe I can't. This would be a patient safety issue that you could report to the medical team, which would be the one to report to at this situation. So if you're not so there are situations that are mandatory reporting, and DSHS gives training about this. If you want to know more about it, there's long trainings about it to know which situation exactly falls under it. As a DSHS interpreter, you fall under DSHS as mandatory reporters, but in regards to self-harm, it's permissive reporting, meaning whenever you're not a mandatory reporter, meaning you have to report if there's abuse situation of your patient, or abuse situation of a vulnerable adult. A vulnerable adult is someone who is a hospital patient. So that would mean mandatory reporting. You have to report it if that's going on and you know about it. But reporting means to the medical team or the supervisor, or that would be us letting Avalon know. Permissive reporting, so self-harm falls under permissive reporting. Even mandatory reporters are not obliged to report it by law, but it is encouraged, and you are relieved of your confidentiality if that is the case. So yeah, that is the situation if they're talking about hurting themselves or suicidal thoughts.
The rules might be a little bit different with children also, and I think Children's Hospital has their own rules, but most of the time patients are going to be adults or vulnerable adults here. So yeah, you would go by what she said. So
Yeah, vulnerable adults or child abuse, of course, situations would be such a situation too.
Okay, so number 4. The patient brought her spouse and adult children to an appointment. The son and daughter start a side conversation about whether or not to contact family members in their home country. Okay, somebody new. Does anyone have a thought on this? What would you do?
I'll tell them, first of all, that you can only interpret for one person at a time, that if everybody's speaking, you can interpret. And interpret what they're saying.
So, right, so first, yeah, the thing that you have to point out, you have to stop them. There's multiple people speaking at once. The interpreter, obviously, it's hard enough to interpret one person at a time. You can't do multiple. And so make them aware of that. And maybe they stop talking then, because maybe they don't want their conversation interpreted. But and then if they're having that conversation, that side conversation in their own language, you're either doing it simultaneously if you can, or do it consecutively. Number 5, you meet the patient and family and are told by the adult son that they don't need an interpreter because he speaks enough English. How many people have had this happen? So what do you do? Approval of their provider?
The agency is getting hired, like the interpreter is getting hired by the provider. Provider is the one who is doing the main decision. We're there for the job and not listening like if he's fluent in English or not. So we're just going and reporting about it, but we still stay and interpret.
Right, so can the patient dismiss you and let you leave?
No.
Or the patient's son or whatever. But so the policy at Seattle Cancer Care Alliance is that family members should not interpret except in routine things. So infusion, maybe. I'm reading what.
Yeah, some infusion appointments are considered routine, so it would be fine for a family member.
And so one thing that might help is that if you reassure them that it's all confidential, if that's part of the reason, but that's not always the reason they want to dismiss you. If you assure them that they don't have to pay, if they're a U.S. patient, they're not paying for the interpreter services. Did you have anything more to?
What we see a lot is that patients who actually don't really speak English want to dismiss the interpreter because they are worried about confidentiality. And you guys are so aware that everything will remain confidential, and you signed all this paperwork about HIPAA and the trainings, right? So you're not worried about it, and you're very aware of it. But reassuring the patient in the pre-session everything will remain confidential can go a long way. Just because we had a few patients over the last few months where that was an issue.
And the problem with a family member, what's the problem with a family member interpreting for the patient? Conflict of interest.
Sometimes they don't want to say what's really being said because it can be very.
Right. They might not want to say some of the things. Are they a trained interpreter?
No.
Maybe, but maybe not. So they probably aren't even.
Even if they are a trained interpreter, it's still a conflict of interest.
Yeah, conflict of interest in the fact that they're so emotionally involved. I can't imagine like being with my mom trying to interpret and hearing some sort of bad news or thinking, oh, she won't listen to this anyway, so I won't tell her that. I mean, it's not an effective.
I would just add that don't rely so much on the provider to determine whether or not you're to stay, because some of them are wonderful and some of them understand that a family member should not be serving as an interpreter for a patient. Some of them are like, oh yeah, his son can interpret, you can go, and that's not okay with us. So.
There was a situation where the husband wanted to interpret everything for the wife, and he was very rude. The interpreter when he would say, "No, I know everything. I speak 5 different languages and so on." But and he was totally rude, trying to dismiss the interpreter. And the doctor said, well, no interpreter has to say, but he wouldn't allow the interpreter to do the job. Like, he kept interrupting that. So at any given time, he was talking about the provider was explaining the wife that she was going to receive several treatments for life, and that was going to be, of course, a weekly thing. And then the husband asked, well, do not interpret this, telling me directly. And he was like, and then at the time of interpreting his dedication and explaining to the provider, okay, this is going to end, but I'm going to keep interpreting to the wife. And then all of the confusion, he was telling the wife, the doctor, what if she doesn't want to keep on going the treatment because she's tired and she doesn't feel good and the side effects are really hard on her, but what if we leave this to natural course? When it's going to happen. So at that point, you have to report all those situations. And I really be very careful where to report this and where to come again out of this comfort zone and talk with the provider. The whole situation is just not right. So that's just one example of what can happen when a family member interprets, and the patient is typically dependent on what's going on for taking the decisions for what to do with their own lives.
And hopefully the providers would know that it shouldn't be the family member doing it. I've had the same thing where some family members, and the woman was very aggressive about she didn't want me interpreting, and she would do it. It's a very uncomfortable situation. But
it is uncomfortable, but some providers say, well, this is okay, but I think you have to report or give some, I think, documentation of what actually happened, and with the different parts involved in it and the decision, because this is not, normally speaking, we don't interpret for a patient once. We keep on interpreting for the patient over and over and over again for years, many times. So I think there has to be a precedent for what happened in the situation. And some clinics that say, well, it's okay, you can, we are comfortable, and this patient doesn't need an interpreter because the mom just wants her son to interpret for her all the time.
But so basically, at the Cancer Care Lines, they're not, the provider cannot dismiss the interpreter for that kind of thing.
But at that time, you involve interpreter services, because you cannot, as an interpreter, be fine against what we're all the time.
Right, yeah.
Job,
when things get really tough, you need to contact.
You can remind them of the policy, and family members shouldn't interpret per SCCA policy. You don't need to insist. It just creates conflict. So if this continues happening and you interpret and the son interprets over you, then, well, just let us know, and we'll let Evelyn know, and Evelyn will take the steps to talk to the care team and contact the patient if needed.
Are there any specific ones you want to hit, or just do another one maybe?
Actually, to this, I also just still wanted to say, well, the family member also has a different role. It's really busy. Remember how it is when you were interpreting for your family, at least for me, before I actually learned about interpreting, having to participate in the conversation yourself and then interpreting. It's exhausting. But if you are a family member who's not aware of interpreting, hasn't really done it, then they're really not aware what they're getting themselves into. So they're already having a role of supporting the patient, right? Which and they should provide their own input, right, and their support. So they have a different role as well.
What about number 15, maybe? No? 15?
Oh, okay, yeah. So suggestions on which scenario you would like to cover. We just heard number 15.
And Evelyn just said 7 and 13, so maybe we'll do those three.
I think I kind of feel like we have been covering questions as we've been going, unless there's still someone who would like to bring their question now, since we had allocated the last 15 minutes for questions and answers for your scenario. So if there's still one on the list that you would like to discuss, let us know, or if there's any scenario yourself that you have yourself, otherwise you'll just keep going down the list.
I have a few slides.
15.
But I'll skip. So just keep going on scenario. With 15? Okay, 15 is You're an interpreter who speaks more than 2 languages. You arrive for the appointment and realize that the patient and family come from a region where a dialect is spoken that differs significantly from the standard language. I take it you've encountered this?
Even like, let's say, to be specific, what was that? Creole. Creole is not French, but it's so it's kind of Caribbean
Yeah, yeah.
language. You can understand them, but they would have hard time to understand your French because if you keep it standard French. So what would you do in that situation? It's an emergency situation, like they couldn't find an interpreter, things like that.
Well, if it's basically the kind, in my opinion, would be that when any situation where you realize you can't really adequately interpret for the person, that you make them aware of that situation, and then they would work on getting another, whatever other type of interpreter they could have, whether it was phone or video.
Yeah, we would typically move to telephonic, and then we would appreciate you letting us know so that we can make a note in the patient's comments and say, please do not, get a French interpreter, but rather,
it was a mental institution. So what can you say? Help us as much as you can.
Well, and I'd imagine once you've made that clear that that's the limitation, then, and if you're there helping until they find the better situation, then I'd imagine.
Kind of similar to what you said with the chaplaincy. Remember at the chaplaincy or spiritual, existential, and religious distress, she was saying that in the situation where you don't really know the terminology of the prayer, if you let them know, if you let the provider know and the patient, then they can rework that situation, right? And the same thing here. If you let them know, they can either decide, oh, we're just going to get a Creole interpreter for next time, and then Evelyn will be looking. If they can't reschedule and it's right, then, well, they will probably ask you help us as much as you can, but at least everybody's aware of the situation.
Was there a comment over here?
Yeah, it's just I can speak loud, I think. Do you?
Yeah.
It's just I do Swahili, but I do also Kirundi. Then Kirundi is in my mother tongue, and it is spoken in one country. But Swahili is spoken in Tanzania, in East Africa, Central, but different Swahilis.
Yeah.
So the people I translate often are from where I come from. So Congo, and we were just discussing with her because she's from Tanzania, and the Swahili from Tanzania is quite different from the Swahili from Congo and Burundi, but it is Swahili. And here legally it is Swahili. And when we get the jobs, translator, and Swahili interpreter, oh fine, great, let's go. But sometimes I find that they are from Tanzania, and I have to ask them, do we communicate? So, like most of the people coming from, immigrant coming from East Africa, from Burundi, Rwanda, and they speak Kirundi. So I ask them if which one they are comfortable with, because there are some terminologies they don't understand, they cannot in Swahili. So then I do translate in Kirundi. So things like that. I don't know. If it did, I help with it. But although I get that job in Swahili, and I see them not understanding, I'm like, okay.
And you would let us know.
Yeah,
you let us know.
Yeah.
I think it would be better if this patient, I feel the patient is not understanding.
Yeah.
It would be better to have an interpreter for Swahili with this dialect coming from this region. And that way we know more specific about it. It's hard sometimes for intake for people who have no idea what the language is to know.
And that's what I was wondering. Like this could be an education piece for our intake department. Like for languages like Swahili, it's helpful then to get what country. So not just get, okay, you speak Swahili, but find out where are you from, what country are you from, and that's going to be a better match. Are there other languages spoken here for which that is true?
Spanish. I
Yeah,
mean,
tons of dialects.
So tell me a little bit more about that, because my sense is that, you know, if you're from Spain, if you're from Mexico, if you're from Peru, if you're from Ecuador, if you are from, you can probably understand standard Spanish.
Right.
Unless it's a
Right. There could be an indigenous dialect.
Yes, that is different.
And where their communication, where they're where they're limited in Spanish communication to the degree where they only speak in present tense at all times, as an example. So then comprehension becomes a huge problem.
Okay.
Communicating that to the provider is one thing, but if it's a difficult language like mum, you know, to get a hold of, sometimes the provider just doesn't want to do it, or the patient will say, no, I want to do it in Spanish. That kind of thing.
Okay. What about other languages? French.
You have Belgian French,
Yeah.
which is slightly different than the Hexagon French.
Okay.
And then Quebecois, as you know,
Yes.
which is like an old French. I did that, but I have like the glossary. So I prepare usually myself ahead of time, things like that.
And Creole.
Okay.
And Creole is a
And
part of
Creole.
that.
We have
You had one?
we have a large population of Taiwanese
Okay.
in Seattle, who is a different dialect than Cantonese.
Right.
Taiwanese, they do understand most Cantonese, but they do not speak Cantonese.
Okay. Okay.
So those are the difficult assignments.
Yeah.
Anyway, let me know one time that, oh, this patient actually speaks Taiwanese. I feel worried about it. Can you remove me or not schedule me for those anymore? And
So if you
that's
know
I think with
Taiwanese,
yeah,
you need to find a Taiwanese.
with the Chinese languages, I think we can break it down in the request more specifically. With Spanish, we can also, to some extent, the indigenous, dialects are in there for us to choose. With Swahili, I know for sure that not. It's just Swahili. They don't ask what country. Other languages for which it would be helpful to know what country they're the speakers from.
Do you have Ukrainian interpreters? Because sometimes Ukrainians, they all speak Russian,
Yes.
but they don't want to talk
Yes.
maybe because it's some barriers. They understand more than speak.
Mhm.
And you come to the appointment and it starts like, she starts in Russian and blah, 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 and it goes to Ukrainian, which I don't understand,
Yeah.
And I keep telling her and she gets frustrated. I keep telling her, and because I don't understand what she wants to say. It's supposed to be accurate. So that's why I know we don't have that much Ukrainian interpreters, though.
No, you don't. But that is a language that we are able to select specifically that
Right.
language if the patient says that's what I speak.
Yes, that's why I'm now just trying to learn Ukrainian to understand what they're saying, but I cannot be fluent because it takes so long time, to learn that language. So.
And basically what we have is sometimes it's the option of getting the more common language or not having an interpreter at all. There's always, if that's the situation that they speak a dialect or something, then basically we try to let us know, and then we let Evelyn know, and she either can sometimes pre-schedule telephonic appointments with someone from exactly that dialect, or otherwise, if that's not available, there was a situation where you couldn't find a telephonic pre-schedule for that dialect, and what we have to do is work with the best that we can. So if they then speak the other language not as fluently, but it's not their native tongue, then just make sure that you do your best and let them know when you don't understand. Yes. And for Russian, Ukrainian, yes, we don't have as many Ukrainian interpreters as Russian interpreters. Usually we ask them to let us know if they're fluent in both and to put the note native in Ukrainian, but also speaks Russian. So we'll try to get a Ukrainian interpreter first, or same for other languages, right? We try to get their first choice first. If we can't, then we'll do the Russian, or then we'll do the Mandarin instead of the dialect, so that they get still interpretation services as much as as possible.
It gets a little tricky though when we start to deal with not so much levels of education, but handicap, mental handicap, where comprehension is very, very difficult, especially in issues that are as complex as this.
Yeah.
And I mean, I know that at Children's, they will provide a navigator to get the person or the family, you know, kind of through that process for the sake of creating medical literacy transparency. I've been asked a few times, you know, if I can explain, and I have to explain to the provider that it's not my role to explain, but I will interpret everything that you say. But still, there are some details, some complexities that honestly, I don't think they got across.
Yeah, and you can never know for sure whether someone has understood. I mean, you don't know, and when people are dealing just in English, people don't necessarily understand. There's two more that Evelyn had asked, and we have 5 minutes, so I think might just read them out, and maybe you can give them the short answer. So number 7, the patient has an MRI appointment in the radiology department. The radiology staff takes the patient into the MRI room, tells you the MRI will take about an hour. It's getting close to lunchtime. You want to eat and check your messages. What do you do?
Usually where they ask you to wait for the patient. They sometimes ask you to wait for the patient outside the little room, or sometimes they ask you to wait for the patient next to the, well, you have to be reachable.
Yes, you have to be reachable. You ask them.
You need to be where they can reach. I'm sorry, what? So you need to make sure that they know where you are. If you aren't going to be right there, that they need to be able to get hold of you.
Yeah, coordinating with the desk, and they will then coordinate with the tech, and they'll get a hold of you.
But you should wait in the lobby of the second floor radiology. Don't go to the Red Brick and hang out there, or, you know, the resource center. I mean, like, wait in the lobby. You know, yeah.
Could you clarify number 10? Because it does have.
And English, this is one that got requested. An English-speaking family member disagrees with your interpretation of a word or sentence. Take one.
They have the right to fire their interpreters, yeah? Patients. It's patient-centered, anyway, yeah?
So if the patient or the family member disagrees, they can fire you?
No.
And then you get to go home?
I mean,
and you still get paid? When
not like in the short term, but in the long term, they say, oh, this person is not up to, yeah.
Well, I'm sure that they have the ability to complain, but whether they are, who knows if they're even right. But what I would say is, first of all, that you listen to their input, because maybe they are right. I mean, they know the situation better. They know, like, they know their family member. They know how they talk. I mean, or maybe they know the medical terms. So listen, and if it turns out that they're right, then acknowledge it, interpret a correction, blah, blah, blah. But if they're not, I mean, and at the same time, let the provider know what you're doing. You do the transparent thing. But if they're not, then the interpreter stands by her interpretation.
So you can ask for a moment to check it, like on your dictionary or whatever, and then say, I stand by my interpretation, or you're right, I made a mistake, or interpreter made a mistake.
Or maybe it wasn't the wrong term, but just instead of the more medical term, it was more the layman's term, and
this is or maybe it's the Spanglish. I mean, like, when you use the right Spanish term, people don't know what you're talking about because they use whatever, the English word with the Spanish pronunciation. So.
And in Spanish, we have when we use solo, and the medical term for pagar, which is, in little towns in Mexico, it sounds like a French. So once it was interpreted for patient, it was using the term pagar, and that was very, very angry. And it's like, when it was saying that her daughter would be like an animal. Oh no, it does too.
Well, and so the goal in the thing is to facilitate the communication, right? So it's not about being like, I'm right, I'm the interpreter, so you can't ever say I'm wrong. You want to understand where the comment's coming from. Hopefully they're going to be willing to work with you too.
If you were super angry at a time and say, but the new specification, you have to clear out, where's the anger that's coming out.
Well, the inverse of that is, in Spanish, a lot of people in Latin America will say, my hand hurts.
Yeah.
But they really mean, and they're going like this, and so then you gotta have to stop.
Just have to clarify.
The interpreter needs to clarify that they mean actually hand on. So do the same for foot, but
10 seconds on number 13. You'd requested 13. The nurse is, I think this is pretty clear cut. The nurse is giving the patient's family a list of new appointments and is asking if you are available to be their interpreter.
Oh my.
We don't. Which one? You have to contact the company, the agency.
Can you sign yourself up for that appointment? No.
No, like you, I think you do the section and you have to interpret that.
Yeah.
That's the nurse trying to do, the nurse trying to do that. It may be a reason for that you have to follow a pathway here. It goes to reception desk or services. You cannot find yourself.
It's right. You have to. They need to. The provider needs to contact.
Yeah, they gotta be a valid reason maybe for what you're being asked to provide that service.
You cannot just say, yes, I'll be there. No, that does not work. I wouldn't know. You wouldn't get paid. I mean, there's no record. This doesn't work. Maybe you'll get some other appointment, forget about it. This is all heading in the wrong direction. But in general, we're trying to be patient-centered. If there's a patient who, don't market yourself for appointments, don't go after their schedules, but if a patient says, but you already know everything about my treatment and I've seen you so often and it would be so much easier if there's more continuity, and if it's really important to the patient, you can let them know. I cannot request that, but you can talk to interpreter services and make that request yourself, or they can talk to the scheduler, and the scheduler will know what to do, or just call us. And this request cannot come from you. If you call me and say, oh, but this patient said they want me, it's a conflict of interest if you say that, right? Because you basically, so it does need to come from SCCA. You can tell the patient if you ask the provider, or if you ask the scheduler, that then we can make arrangements. It's no guarantee that you will always be the one. Basically, we will try to ask, of course, we'll always try to ask you first, unless you're already scheduled with a different patient. But if you may already be assigned somewhere else, or you may not be available, right? But we'll try to prioritize to schedule the preferred interpreter. If we can't, then we'll schedule someone else.
When you encounter a situation as well, let that patient know that the other interpreters that work here at SCCA are really well trained and can assure that they will get an interpreter who will cover it.
That would also be something very solidarity. Yes. Thank you, everybody. Thank you, everybody, for being here today. Remember, actually, we saw that everybody was still here, so you don't really have to sign out, but please give your feedback form to Rima on your way out, because we really value your input. Thank you so much for coming today.